and welcome to the Hypertension Series. This is volume 3 of the Hypertension Series. This is a series of talks that were delivered in the meetings of the Hypertension Task Force. This volume will focus on the SPRINT trial. The idea of the Hypertension Series is to go through all of the available data that we have about hypertension and to discuss the available hypertension guidelines and what that means for the individual physician and what that means about what's unknown and what is known and how we can use the guidelines to best treat the patients and to achieve the best outcomes for our patients. So the SPRINT trial is the systolic blood pressure intervention trial. So this actually started even as early as 2007. The National Heart, Lung, and Blood Institute expert panel hypothesis was that a lower systolic blood pressure goal would reduce clinical events more than a standard goal. So the SPRINT trial, which actually culminated in about 2015, it was designed to compare the benefit of treatment to a systolic blood pressure target of less than 120 millimeters of mercury with treatment to a target of less than 140 millimeters of mercury, which was considered the standard treatment. The primary composite outcome was myocardial infarction, other acute coronary syndromes, stroke, heart failure, or death from cardiovascular causes. Patients with age of at least 50 years were included. They had to have a systolic blood pressure of 130 to 180 millimeters of mercury, and they had to have an increased risk of cardiovascular events, as defined by clinical or subclinical cardiovascular disease other than stroke, GFR of 20 to 60 milliliters per minute per body surface area, excluding polycystic kidneys, a 10-year cardiovascular risk of 15% or greater on the basis of Framingham risk score, or age of 75 years or older. They did exclude patients with diabetes mellitus, prior stroke, and polycystic kidney disease because other trials, NIH-funded trials, were ongoing at that time, which were designed to test similar hypotheses in these populations. So they started off with about 14,692 patients, and ultimately 9,361 were randomized, 4,678 in the intensive treatment group, and 4,683 in the standard treatment group. We'll talk about standardization, but the blood pressures were measured by a standardized technique, and this actually becomes a very important point, and we'll discuss that closer to the end of this talk. So you can see that the baseline characteristics were pretty similar between the intensive treatment and the standard treatment. Age greater than 75 were about 28% each. Chronic kidney disease subgroup was about 28% in both the intensive and standard treatments. The Framingham 10-year cardiovascular risk score greater than 15% was similar in both groups. The females constituted about 36%, and the Black subgroup, the Hispanic subgroup, and the white subgroups were similar in both the intensive and the standard intensive and standard treatment groups, and the whites were about 60% of the patients in this study. But as you can see, about 30% were Black, 11% were Hispanic. So the SPRINT trial had a significant CKD subgroup. As you can see, among those with estimated GFR less than 60 milliliters per minute per body surface area, the average GFR was around 48, and among all participants, the mean GFR was around 72, uh, and there was mild to moderate albuminuria with an average albuminuria of about 44 milligrams per gram. Statin use was among 40%, aspirin use was 50%. Almost half of the patient population had a smoking history, whether it was former smoker or current smoker. And the Framingham 10-year cardiovascular disease risk score was 24.8. So significant cardiovascular disease amongst the SPRINT patient population. The average body mass index was close to 30, so a significant proportion of the population was in the obese category. The mean systolic blood pressure that was achieved in the intensive treatment arm was around 121 millimeters of mercury, and the mean systolic blood pressure in the standard treatment group was below 140, but significantly above 130. So you can see that greater than half the patients in the intensive treatment group did not achieve a blood pressure less than 120 millimeters of mercury on a consistent basis. The mean number of medications in the intensive treatment group was about 2.8, and the mean number of medications in the standard treatment was about 1.8. You can see that the primary outcome was significantly lower in the intensive treatment group. Heart failure was significantly lower. The incidence of heart failure was significantly lower in the intensive treatment. Death from cardiovascular causes was significantly lower in the intensive treatment. Death from any cause was significantly lower in the intensive treatment group. And then as far as kidney outcomes, there was a significantly increased incidence of 30% reduction in GFR in the intensive treatment group. And this is primarily thought to be a hemodynamic effect, which is also seen with RAS inhibitors, which is also seen with SGLT2 inhibitors. And this initial decline in GFR is thought to be a hemodynamic effect. And the long-term effect of intensive blood pressure lowering is thought to be renoprotective. And here you can visually see that the primary outcome was significantly lower in the intensive treatment group. Death from any cause significantly lower in the intensive treatment group, which is in the orange. In terms of subgroup analysis, all the hazard ratios are in favor of the intensive treatment group. Again, these large trials are not powered for subgroup analysis, so the p-values would not be expected to show statistical significance, and they do not, but the trend is significant. The direction of the data is significant. So in terms of adverse events, you can see that hypotension was a more frequent event in the intensive treatment group. But orthostatic hypotension was actually less frequent in the intensive treatment group, and these were statistically significant findings. Acute kidney injury was more frequent in the intensive treatment group, but again, this is thought to be hemodynamic, and intensive blood pressure goals are thought to be renoprotective over the long term. So other than what we've already discussed, there are significant strengths of the SPRINT trial. The participants in the intensive arm were seen 20 to 30% more often for blood pressure management. So this provided greater opportunity to report adverse events. The SPRINT sample size was twice as large as ACCORD. And we'll talk about the ACCORD trial in the next volume of the Hypertension Series. The SPRINT trial included a cohort with chronic kidney disease, whereas ACCORD excluded patients with serum creatinine greater than 1.5 milligram per deciliter. So the SPRINT trial was able to show the direction of the data in many subgroups, even though large trials are never powered for subgroup analysis in a statistically significant way. SPRINT flaws was that individuals with diabetes, stroke, and polycystic kidney disease were excluded because of other ongoing NIH-funded trials. We cannot technically comment on intensive blood pressure lowering in those populations. But again, the expectation, and I think it would be reasonable to believe that the benefits of intensive blood pressure lowering is also applicable in those populations. The clinic staff were unblinded to randomized assignment. The clinic staff were the ones that reported adverse events, but the physicians were blinded. So important points from the SPRINT trial is that the potential for harm was offset by the positive effects of more intensive blood pressure control rather than standard treatment on total mortality and the primary outcome. 3 blood pressure readings were taken with proper cuff size, participants seated with their backs supported, 5 minutes of rest before measurement, no conversation during the rest period or during measurement, and using an automated manometer. Blood pressure measurements taken without observing these conditions may overestimate blood pressure and result in overtreatment, with the potential for high rates of serious adverse effects and greater utilization of resources. So again, these trials, which study intensive blood pressure control versus standard treatment, were done with standardized blood pressure measurements. So they're not necessarily applicable to non-standardized blood pressure measurements, nor would we expect them to, and applying them to non-standardized blood pressures may actually do more harm than good. So standardization is important. Again, the mean blood pressure was 121 millimeters of mercury, so greater than half the participants did not achieve a systolic blood pressure that was consistently below 120 millimeters of mercury. Participants in the intensive group compared with standard group took an average of 1 more antihypertensive medication. So 2.8 medications versus 1.8 medications. So patients who are requiring marked polypharmacy may not be suitable for application of the less than 120 millimeters of mercury blood pressure goal. Again, remember that these guidelines are not meant to be blanket guidelines. They should be individualized, and they shouldn't just be applied to patients in a blinded fashion. So yeah, if they have a resistant hypertension and they're requiring 5, 6 antihypertensive medications, then that intensive blood pressure goal is not applicable. Though the expectation is that the initial GFR decline in the intensive group is likely due to hemodynamic changes, the possibility of permanent renal injury or CKD progression cannot be excluded. No conclusions can be drawn concerning diabetics, polycystic kidney disease, or prevention of recurrent strokes. But I think that when studied, the results will pan out, and the intensive blood pressure lowering will be applicable and beneficial in these populations as well. So greater absolute risk reduction was seen in those with higher baseline cardiovascular risk. So again, that might be a consideration to think about when you're treating patients. If a patient has higher cardiovascular risk, then perhaps the intensive blood pressure lowering would be a more applicable, more valid goal to have. Consideration should be given to incorporating cardiovascular risk when making decisions about blood pressure lowering. There is a potential for increased cost because of medication titration, close monitoring for adverse effects, and more frequent patient visits, but the potential for savings related to reductions in hospitalizations due to cardiovascular events potentially outweighs the increased cost. In the next volume of this series, we will do a review of the ACCORD trial. We'll discuss its strengths and weaknesses, discuss how it contributed to the establishment of blood pressure goals, and discuss what remains unknown or uncertain. Thank you very much for watching. I will always end these talks with a couplet of the month. The couplet of this month is by Samuel Taylor Coleridge. Common sense in an uncommon degree is what the world calls wisdom. Thank you very much.